we start? So we'll start again. Okay. Good evening, everyone. I welcome you all for this last presentation on valvular heart disease, and the name of the topic today is TAVR follow-up. TAVR is transcatheter aortic valve replacement, and we'll be discussing how to follow up these patients. So as you all know, the most important thing for a patient who has undergone a valve replacement is anticoagulation and antiplatelets. So at present, anticoagulation is not indicated for transcatheter aortic valve replacement patients until unless they have a specific indication for anticoagulation, like presence of LA appendage clot, atrial fibrillation, DVT, or pulmonary thromboembolism. These are the only indications where anticoagulation would be given to a patient who has undergone a transcatheter aortic valve replacement. So what do we give to these patients? Dual antiplatelets for 1 to 3 months, followed by single antiplatelet lifelong is the current strategy. But how are the surgical tissue valves managed? In the surgical tissue valves, still majority of cardiologists and cardiac surgeons in India are giving anticoagulation for 3 months, followed by just a single antiplatelet lifelong. So do we notice any bioprosthetic valve thrombosis? Yes. So the concept of bioprosthetic valve thrombosis has been solidified since the TAVR has started. What was noticed in some patients is the gradients had gone up on follow-up, and when you do an imaging, there would be a thrombus which would be present on the bioprosthetic valve leaflets, as you can see in this picture. In the first picture, which in the first row, you can see how the thickening of the leaflet is present. So there is a term called halt and ham. Halt is hyperechogenicity with leaflet thickening, and ham is abnormal mobility. So if the leaflets are thick on a 4D CT scan, most likely this is a thrombus which is present on a bioprosthetic valve. And why this thing can happen is because of different properties of the leaflet, and also due to the different dynamic forces which are generating at the level of valve. Now, if you remember, in a transcatheter aortic valve patient, the native leaflets are still there. There is a calcified material which is present in the sinus of valsalva, and because of that, there can be more eddy currents and forces which can generate at this level, and this can affect the leaflets. And because of the stasis of the blood in the sinus of valsalva, there can be a thrombus formation. Also, the metallic frame which is present in the transcatheter aortic valve patients can be a nidus for a thrombus formation. So these are the various factors which can lead to formation of thrombus in patients who have received a transcatheter aortic valve replacement. How do you suspect, or when do you suspect? So if you have a transcatheter aortic valve replacement patients on follow-up, and if you notice, as you can see in this echo, there is an increase in the gradients over a short period of time. So you see in this patient, the mean gradients have increased to almost 40 millimeters of mercury, which was not there in a prior follow-up, which was done almost 3 months post-procedure. So what do you do in such patients? You do give them anticoagulation for next 3 months and maintain an INR between 2 and 3. The other important thing which I would like to highlight here, what is the difference between incidence of bioprosthetic valve leaflet thrombosis between the TAVR and the surgical aortic valve replacement? So it is slightly more in the TAVR patient. There is no statistical significance. Also, it is more in patients who have received either a larger valve or who have received a very small valve. Also, it is higher in patients who have received a valve-in-valve procedure and the prior tissue valve was a very small valve. So in my practice, I would give anticoagulation to following category of patients who have received TAVR. Number one, a young patient. Suppose a patient is in 6th decade, 62, 63, 65-year-old, and a patient has a bicuspid aortic stenosis, I would give them anticoagulation for 3 months. Number two, a valve-in-valve patients where The prior valve is the 19 millimeter valve, and because of that, there can be higher gradients. Number three is if a patient has increased gradients on follow-up, I would give them anticoagulation. Also, if I'd done a valve, mitral valve in valve, I would give them anticoagulation for 3 months. The second thing which you have to follow up in these patients is infective endocarditis. The incidence of infective endocarditis is around 1.1%, and the risk is similar to as for a surgical bioprosthetic valve. So what is the treatment of infective endocarditis? It is standard how you would treat all infective endocarditis in a tissue valve. The same protocol is followed. You do send them for culture and give them the appropriate antibiotics for at least 4 to 6 weeks, and then you can tailor your antibiotic regimen based on the bacteria which grows in the blood. Surgery. When is the surgery required? So if there is a mechanical complication, like if a patient has a central aortic regurgitation, then we have to suspect infective endocarditis in such patients. See hemodynamically compromising aortic regurgitation, or a severe aortic stenosis, or a recurrent emboli which are happening from the large vegetation on the leaflets. So these are the indications where you would send this patient for surgery and not for a redo TAVR. The reason is if you do a redo TAVR in presence of infective endocarditis, the vegetation is still there and that it can infect the new valve as well. Patient process mismatch and valve failure. This is very important for us to understand. What is patient process mismatch? Patient process mismatch means the processes which you have put inside the patient is smaller for the patient's body surface area and the cardiac output which is being generated. And by definition, if the effective orifice area is less than 0.6 centimeter per meter square, there is a patient process mismatch. So these patients would have symptoms anyhow on follow-up also. Their dyspnea would be there. The LV reverse remodeling will not happen. They'll have diastolic heart failure. Also, the valve can degenerate faster. So I'm not going to show you here in detail, but what we can now do is we can tailor a valve to a patient's anatomy in such a way that the patient process mismatch can be avoided. Now, if a patient has a very small root, something like a 17, a 16 mm, they should undergo a surgical valve replacement with root enlargement. So if a root enlargement is not done, then there is no point. So the effective orifice area of a TAVR valve is more than the effective orifice area of a surgical valve because of multiple things. There is no sewing ring. However, there are new surgical valves which are out there in the market which have a better effective orifice area. The thing is, aortic. The next important thing which you have to see on follow-up is aortic regurgitation. So a follow-up echo at one month, 3 months, 6 months, and 1 year is very important in TAVR patients, and we need to look at aortic regurgitation. What happens in majority of cases if a patient has mild aortic regurgitation post-procedure, then the aortic regurgitation decreases on follow-up. However, if a patient has more than mild aortic regurgitation, this regurgitation can remain same or in fact can increase. So it is very important on follow-up to quantify the aortic regurgitation and whether the aortic regurgitation is responsible for new symptoms which the patient is having, or it could be the reason why patient never felt any improvement post-TAVR. So if you see any significant regurgitation, then we need to decide the treatment modality, why it is there. Is the valve frame unexpanded? Is the valve too high? Is the valve too low? Or is the valve small for the annulus? Whatever the etiology is there should be corrected either by doing a post-aortation, by putting a new valve, or by putting a plug for the paravalvular leak. But in the present scenario, where we have moved down to the low intermediate risk and younger patient, a patient cannot leave the cath lab or cannot have more than trivial mitral regurgitation. In the first generation, in the first in man trial, which was high risk, it was shown that mild AR does not affect the long-term outcome, but that is not true anymore in the intermediate risk profile. Even presence of mild paravalvular leak has poor outcome at 1 year. So the patient should leave the cath lab without any paravalvular leak or with less than trivial paravalvular leak. So with the present generation technology, only 5 to 6% have more than mild AR. And that is because of the skirt, which is there on the outside of the present generation valve, which could be a Evolut Pro, a Sapien 3, or a My valve, which have a skirt on the outside, and because of that, the paravalvular leakage is less, and we get good sealing in such patients. The next thing which needs to be followed up in these patients is presence of conduction abnormality. What all can be seen? A late complete heart block. Very rare, but it can happen in a patient who is undergone TAVR and on follow-up. Number two is left bundle branch block, atrial fibrillation, right bundle branch block, bifascicular block. So if you see there is increased chances of permanent pacemaker following a TAVR if a patient has baseline right bundle branch block, if the valve is deeper than 5 millimeter. Number three, if a patient has a very short membranous septum and the depth of implantation is more than the length of membranous septum. And number four, if the valve is more than 20 to 25% oversized compared to the annulus. These are the four important factors which affect the patient's conduction system, and there can be an increased chance of permanent pacemaker. So if you see these patients on follow-up, EKG is very important. You need to identify all abnormalities in the EKG and also compare it from the baseline. These are the incidence of pacemaker post-TAVR. We all know in a self-expanding valve, the incidence of pacemaker can go up till as high as 25 to 30%. In a balloon expandable first generation valve, which was around 10 to 12%. In the latest generation balloon expandable valves, which is Sapien 3 and MyValve, the pacemaker rate is less than 6%. And in the MyValve trial, the pacemaker rate is around 2%. Now, also with the self-expanding valve, the Evolute R and Evolute Pro, with optimization of the valve implantation, the pacemaker rate is coming down to less than 10%. Stroke, very important. It is very important for us to follow up these patients. The majority of stroke happen during the 48 hours, but still the stroke rate, there can be a stroke on follow-up. Now, if a patient, if you see a patient in your follow-up who has undergone TAVR, now is 3 months post-TAVR, and now you have noticed that patient has developed a TIA or patient has developed some sort of thromboembolic manifestation, there are two important things which needs to be ruled out. Number one, bioprosthetic valve thrombosis. So the reason why I want to highlight this point is, if a TAVR valve develops a thrombus on the leaflet, there is a possibility that that thrombus can break and go to the cerebral circulation or to the digits. So if a TAVR patient on follow-up develops a TIA or a stroke, there is a high possibility of bioprosthetic valve thrombosis. And number two is if a patient develops a new onset atrial fibrillation. Again, such patients can develop a stroke or TIA on their follow-up. So it is very, very important to see for the leaflet thickness. Now, such patients can be asymptomatic. So that's why you want to call them as asymptomatic bioprosthetic valve thrombosis. They have no symptoms, no dyspnea, nothing. But on the echo or on a 4D CT, you would notice thickening, increase in the thickness of the leaflets and presence of a thrombus. So that's very important. So I'm going to share my own experience of my single center where I have completed 107 TAVR cases, but the data which we are showing is only of 105 cases. The average age was 72.9. The average STS score was 2.79. And then majority of patients were symptomatic. Angina was seen in 28 patients, syncope in 10 patients, diabetes in 25% of patients, and standard other factors. EKG, atrial fibrillation was seen in 3% of patients, left middle branch block was in 4.8%, 3 patients had baseline pacemaker, and then 5% patients had right bundle branch block. About the valve morphology, 31% of patients had a bicuspid aortic valve, and this is what we are seeing in the Indian subcontinent, that majority of patients have bicuspid aortic stenosis. Mean gradient was 47.5 millimeter of mercury, peak gradient was 75.7 millimeters of mercury, and mean index aortic valve area was 0.29. The mean PA pressure was 35 millimeters of mercury. Procedural characteristic. 104 patients, all of them underwent conscious sedation, minimalist TAVR procedure. Intubation was done in only one patient. The mean procedure fluoroscopy time was 24 minutes, mean procedure time was 61 minutes, mean contrast volume was 82 ml, pre-dilatation was done in 54% of patients, post-dilatation was done in 27% of patients, and the percutaneous femoral access closure was done in all the patients. There was no surgical cut down pre or post, and proglides were used in all the patients. Procedure success was 99%. There was no intra-procedural death. The valve sizes which were used was 20 mm in 3.8%, 21.5 in 1.9%, 24.5 in 2.8, and 26 and 23 millimeter were the majority of the sizes which were used in India. 2 patients required femoral stenting and ballooning for their peripheral complication. Procedural outcomes. All-cause mortality was 1%, was 0.9% post-procedure, and at 30-day also 0.9%. Procedure mortality was 0. Stroke was seen in 2 patients, disabling stroke in 1 patient, non-disabling stroke in 1 patient. New permanent pacemaker implantation rate was only 5.7%. The paravalvular leak, moderate paravalvular leak was seen in 1.9%, mild in 2.8%, trivial in 6.6%, and 87.6% of patients had no PVL post-procedure and even at time of discharge. Average ICU stay was 26.4 hours, average hospital stay was 5.4 days, and average post-procedure mean gradient was 8 millimeters of mercury. Paravalvular leak, this is the graph showing paravalvular leak. 87% patient did not have any paravalvular leak. And as I said, in the current generation where we are doing TAVRs in low intermediate risk and in patients who are slightly younger compared to patients who were enrolled in the partner to the CERTAVI and the low risk intermediate trials is less. So such patients should leave the cath lab with no PVL. So you see the rate of mild PVL is 2.8%, moderate PVL is 1.9%, and severe PVL is only 0.9%. So this is the outcome which I have compared with the latest low-risk trial. If you see the STS score in partner 3 trial was 1.9, Evolute R low-risk trial was 1.9, the notion was 2.9, and the average STS score is also similar here. The pacemaker implantation rate in the partner 3 trial was 6.6%, Evolute R low-risk trial was 17%, notion was 34%, and my outcome is 5.7%. Mortality almost similar. Stroke rate almost similar. PVL, mild PVL was seen in only 2.8% of patients, and moderate to severe PVL was seen in 1.9% of patients. Thank you very much for your kind attention. I would highly appreciate if there are any questions. You can write me on email or you can text me your questions. I would be more than happy to reply. And tomorrow, the plan is we'll share a questionnaire with you. And this will be kind of a certification course. So we'll also issue certifications of merit as well. So the idea of sharing a questionnaire is to actually kind of highlight the important points which can help in the practice, and also highlight the important management aspects which can be practice changing. So ultimately, this will benefit the patients. They will have better outcome, and their management would be as per the up-to-date guidelines. Thank you very much for your kind attention.